it's really hard actually to have a successful private practice these days. So then what do you do as a physician? Well, you have to be more efficient, right? So maybe see more patients, see more volume to make the same amount of money so that you could pay for the rent, keep the lights on, pay employees, benefits, all these things, right? So it's funny because people may say, oh man, that clinic makes millions of dollars, but a lot of that goes into overhead itself, like, 50, 60%. And then the rest may go to physicians, but it's really tricky because a lot of clinics will fail with that. And because of that, and because it's so hard to be in a private practice, a lot of physicians are now going to hospitals, right? It's easier for them. And they don't have to worry about overhead. They don't have to worry about the business aspect. They just show up, do their thing, and they collect something called RVUs, or relative value units.
If you or someone you know owns an apartment community, listen up. Storyboard Living is actively seeking 40 to 250 unit apartment communities within a 3-hour drive of St. Louis, whether that's Carbondale, Illinois, Columbia, Missouri, or St. Louis County. We're easy to work with and competitive on pricing. You can send information to deals@storyboardliving.com. That's deals@storyboardliving.com. Calvin, thanks for taking the time. I really appreciate it.
Thanks for having me.
You're a very impressive person. You're the first person in healthcare that I've had a chance to sit down with and record an episode with. So I'm excited for the conversation we're about to have. You're a partner at Pain Management Services. And what you guys do is you're experts at managing pain through procedures to help patients avoid major back and neck surgeries.
Yes.
And or neck surgeries.
Right.
And your path to where you are today as a partner, I think, is very interesting. Humble beginnings as a first-generation American, and then completing a very impressive 6-year program in KC.
Yep, Kansas City.
UMKC, is that right?
UMKC, yep.
So if you don't mind, I'd love to hear from you just from the very beginning, how you grew up, where you grew up, and then we'll go through your journey and learn about the business of healthcare.
Sure. Yeah, so I grew up in South County, St. Louis. So that's literally at 255 and Telegraph, right before the bridge to Illinois right there. And where I grew up, I was basically the only minority there. So I did Catholic grade school, and I just remember being the only brown kid at this school. And unfortunately, back in that day, I received a lot of bullying and being made fun of. But the good news is that out of that experience, out of that adversity, it's taught me to be kind to people and open-minded.
So one thing I found interesting the first time we chatted was you mentioned some of the adversity growing up, but you still live in St. Louis. It's just another part of St. Louis.
Correct.
So did that experience make you feel negatively about South County or St. Louis, or were you mature enough? And of course you are today, but even growing up, did you have the maturity to realize that it's not necessarily this entire region or this entire city, it's just strictly maybe the folks that were not being so kind?
Yeah, I think so. I feel that, especially after going to high school and medical school and college, that was probably just an isolated area. My wife, who's also not Caucasian, she's Indian, she grew up in West County and had a totally different experience. And that was interesting to me because when I told her my experience growing up, she felt really sorry for me, So I think that was just my personal experience growing up.
Sure. And it built or helped you build perseverance, determination, which is what it required for you to get into an extremely challenging or hard to get into medical program. So can you touch on why medicine, what led you to the path you're in terms of pain management, and then also what it was like for a first generation kid who maybe didn't have parents that could help guide him through the process, like how you were able to even get to UMKC?
Yeah, so it's funny. We talk about Asian parents, and me and my wife joke about this all the time. They either ask you if you want to be a doctor or a doctor. So those are my options.
Okay.
I joke about that. Not really. I mean, I think my parents would want me to do whatever I wanted to be happy. But I knew they were kind of pushing medicine a little bit. So when I was in high school, before I applied to the 6-year combined program at UMKC, I volunteered at hospitals. I shadowed multiple physicians just to make sure this is something I could see myself doing. And I enjoyed it. And so I applied to this 6-year combined college and medical school program in Kansas City. And there's only a handful in the nation. And it's pretty competitive to get into, about 100 students, 120 students in each class. And UMKC back in the day for that specific program was a lot of people from St. Louis applying or Missouri, because there was benefits to get. You'd get some loan forgiveness if you practiced as a primary care physician in a rural area afterwards. And so a lot of the people, they were trying to get into the program, they wanted to do primary care to get physicians out in these rural areas in Missouri. Now, it's interesting because I went back with my wife for a reunion maybe a couple of years ago, and there's a lot more out-of-state people applying there. And the difference is that I think the tuition's almost like double if you're out of state, but there's a lot of out-of-state folks that apply to UMKC and get in. And so it's like ultra competitive right now.
So assume I don't know anything about medicine, and I don't know a ton. If you're going into a program like the one you went into, at what point do you need to pick the specialty or your niche within medicine?
Right. So great question. Essentially, near the end of the medical school. So in a traditional med school, that's 4 years. You would say in your third year, you're narrowing it down to what your interests are and what specialty you want to pursue for residency. And then after you take your boards, you apply to those residency programs in that specialty that you want to do.
Got it. And did you consider anything else outside of, pain management at that time?
Well, it's funny. I went to this 6-year med school program, and they make you rotate in all the core rotations such as pediatrics, general surgery, internal medicine, things like that, OBGYN, and then any other specialties that you may be interested in. And I think I was getting a little frightened and scared, and I almost panicked because every rotation I did not like. I'm like, what am I going to do? Right? I'm in medical school already. So it was funny because I was on my general surgery rotation, and it's a level 1 trauma center in Kansas City. So we're up at 3 doing a surgery, and I'm thinking to myself, I'm like, this is not for me. And the anesthesiologist pulls down the drape and looks, and then he looks at me. He's like, you need to do a rotation with anesthesia and see what that's about. And I was thinking about it, looking at him, and I'm like, man, this guy's relaxed. It looks like he's having a good time. And it really kind of resonated with my personality. So thank God I did rotate in anesthesiology, because that's an elective. It's not something they make you rotate through. And I didn't really know much of it. So I rotated, and I figured out that that was my personality. And I think a lot of people that go into anesthesiology, they like some sort of structure. They like a little more control of their lives. They like to be in that OR setting, but without the chronic follow-up with patients, right? So a lot of anesthesiologists will go into a surgery, put that patient safely to sleep, make sure the surgery goes smoothly, wake them up, and then they hand them off, which was initially very that was something I really wanted to do, right? It was attractive to me. However, after going through anesthesia residency, being that anesthesia resident, everybody kind of doesn't treat you very well, right? And so that's nurses, that's the scrub techs, you're getting yelled at by the surgeon every time. It's funny because there's a joke in the medical field that, the surgeons are always late and they blame anesthesia. So it's always the anesthesia's fault, right? That we're behind this or that, or whatever. So I got sick of that. And then when I rotated in pain management, which is a subspecialty of anesthesiology, I felt like a real doctor again. And what do I mean by that? I was wearing normal clothes, right? I had a white coat on. I was seeing patients and actually talking to them. They weren't asleep. And it really, I think, came down to my mentor. His name's Dr. Tabaf, great pain physician in Cleveland, Ohio, still practicing, by the way. The way he was interacting and talking with these patients who loved him, I really enjoyed that. And he had such a skill talking with all these patients. He also did a lot of procedures as well. And that's what I loved about it. It's like, hey, I could be a real doctor, talk to patients, have this follow-up and continuity of care. They know my actual name instead of anesthesia. It's, hey, it's Dr. Cajigal. Plus, I got to do a lot of procedures and work with my hands. And, that's like my passion as well. So it was a great combination. The cool thing about pain management too is that the hours are normal, right? It's for the most part Monday through Friday, like 8 to 4, no weekends, no calls. And that's something that was important to me because going into med school, I had this goal, this idea that, hey, I wanted to have a great family life and still practice medicine. And I think this is a specialty that allows me to do all that.
Got it. That's very interesting. So before we really get into pain management, what you do today, and your I guess role as a partner, the fact that you're focused on still practicing while being a partner, and maybe some of the business aspects, I'd love to hear just what exactly the thought process was in terms of like going from residency to, I believe, fellowship.
Correct.
And then, ultimately landing where you are today. I'm sure there's, and I don't know, I don't know exactly how healthcare works.
Sure.
I get a little bit of it.
Right.
But like, I'm sure you're getting tons of offers. I'm sure you can go down the path of maybe working for a large hospital system exclusively, perhaps, versus, maybe being a third party to hospital systems. So if you can give some more background information there, I think it'd be really helpful.
Yeah. So kind of like in medical school, in anesthesiology, you finish residency and then you can go out and practice as an anesthesiologist, putting patients to sleep in a surgery center or hospital setting. However, there's also subspecialties. So you can specialize even more. And let's go through the anesthesiology subspecialties. So that's like cardiothoracic anesthesiology, OB anesthesia, so putting epidurals in pregnant patients, things like that, high-risk deliveries. Pediatrics, you could do regional anesthesia. Regional is using an ultrasound to do peripheral nerve blocks. So limb is anesthetized and the surgeon can do the thing. So that's a specialty in itself. There's pain management, chronic pain management. That's what I do. So that's doing procedures to help with chronic pain patients. The most common patient we see is neck pain, back pain. Try to hopefully help with their pain and try to avoid major surgeries. So when I rotated, and you rotate through all those in anesthesia residency, that's when I really latched on to pain because I was enjoying my experience, and as well as my mentor really resonated with my personality, and I chose that. And so essentially you decide if you want to apply for fellowship, and it's kind of like the same thing when you apply for med school. You're applying to all these different programs, you interview at all these places, and you kind of rank them where you want to end up. And a lot of it has to do with what are you looking for in training? Do you want to go to a big name institution like Harvard, or do you want to go to a place where you think your personality would fit in? Do you want to go to a place that's close to home? There's all these factors, right? And I essentially ended up at University of Iowa Hospitals and Clinics, and that wasn't too far away from St. Louis. I think it's 4 hours or something, or 4 or 5 hours drive. Not too bad. It was great because I could visit my family in St. Louis once in a while. But what really impressed me about the University of Iowa program was that the education was top notch. And what do I mean by that? You can go get medical education at all these different residencies and fellowships, but what they don't tell you is that some of these programs are malignant, right? So what does that mean? That means they can be a total disaster place to work. They may be workhorse programs where you just work and they don't teach you and you're just there for cheap labor, right? There's definitely a ton of those out there. And so the education's not good. And so when that happens, you're out practicing on your own and you may not be well trained because nobody ever taught you anything. So University of Iowa was a totally opposite of that. Great teaching. They didn't overwork you in the sense that you didn't have time to study. And they really wanted you to ask any questions. So that's a place where there wasn't a stupid question. So if you didn't know anything, just ask. And, some medical places where you ask a question, you know how you see it on TV shows, they call it pimping when that attending doctor asks a resident a question and they don't know it. And then they just get berated and yelled at. Yeah. I mean, we've all gone through that as well. And so I had that experience a lot in medical school and anesthesiology residency, but Iowa, I really enjoyed that 1 year. It was really nice.
So the thing that I find interesting about that is, like you mentioned, I think you said workhouse. Workhorse. There you
yes.
go. Where, you're getting cheap labor. So that brings up a very, very interesting point. I'm from Canada. I'm sure folks that are even born and raised in the US, they don't truly understand the business behind healthcare, which
Correct.
is what I'm hoping to get behind
Right.
or get to here.
Yeah.
So when you're thinking profits and doing right by people,
Correct.
what makes a good physician? Is it someone that can balance the two and is doing right by their employer and also the patient, or is it something else? Can you go over in your mind what makes a good physician?
Yeah, I think there's a balance, right? The interesting thing is in medical school and residency, they don't teach you anything about the business aspect, right? You're there to learn about medicine, which is fine. I think there is a big void in that. And I do think the medical students and residents need to learn about the economics and business of medicine for sure. Because when you go out there in the real world, you are not prepared at all. And going back to your question, what makes a good physician in terms of taking care of patients and delivering good care, and then the business side? Yeah, I think there's a way to balance that, right? And there's definitely ways that physicians, they put profits over patients, right? So a good physician will deliver great care and still be successful in the sense that, hey, he's getting a lot of patients because he delivers good care, he gets good outcomes. And so when you're like that, yeah, you're going to get a lot of patients. And I think you're going to get great collections. There's also other aspects too. You got to look at overhead with employees, materials, and all these things are dynamic and evolving. So for example, inflation, and then we got cost of materials going up. Then the pandemic really messed us up with staff and labor, right? So then to find good helpers and good workers, you have to pay a lot more. So your practice has to change a little bit. And what happens with all that stuff, as well as declining reimbursements for procedures? I mean, it's really hard actually to have a successful private practice these days. So then what do you do as a physician? Well, you have to be more efficient, right? So maybe see more patients, see more volume to make the same amount of money so that you could pay for the rent, keep the lights on, pay employees, benefits, all these things, right? So it's funny because people may say, oh man, that clinic makes millions of dollars, but a lot of that goes into overhead itself, like, 50, 60%. And then the rest may go to physicians, but it's really tricky because a lot of clinics will fail with that. And because of that, and because it's so hard to be in a private practice, a lot of physicians are now going to hospitals, right? It's easier for them. And they don't have to worry about overhead. They don't have to worry about the business aspect. They just show up, do their thing, and they collect something called RVUs, or relative value units. Have you ever heard of that?
I have not.
You want me to talk about that a little bit?
I would love it.
So typically in a private practice setting, it's really easy, right? We get collections minus overhead. That's your pay, right? So it's very simple like that. Now in the hospital setting, it's a little bit more complicated. They do something called RVUs, or relative value units. And so basically, an easy way to kind of explain this is, let's say I do an injection. And I'm making these things up. There's actually RVU values for the specific procedures I do. I just don't know them because I'm not in that setting. But let's just say I do an epidural and it's like three RVUs, and then we'll do something more intense like a radio frequency ablation. Let's just say that's 8 RVUs. Well, there's $1 per RVU amount that the hospital will negotiate with that physician, right? So for example, let's just say $60 per RVU or something like that. So that's how the physician will know kind of where they're going, what they're going to make when they do those procedures, right? So the other thing to consider too is in hospitals, they're taking all kinds of insurance, right? So they're taking commercial payers, which may pay really well, taking Medicare, and then they may be taking some uninsured patients or Medicaid patients, and those don't really pay that well. So in order to kind of not have physicians compete against each other, right? They don't really look at that stuff. They just do what they need to do, and they kind of go on this RVU system right there.
So a couple questions on that. That's really interesting. Yeah. Will every hospital offer the same RVU based on the procedure?
Yes. So I think from what I understand, okay, and we can look this up later, but there's a certain amount of RVUs per procedure, and it's like standardized, okay, right? But what's different between hospitals, like for example, let's say like a hospital on this side of town versus this side of town, the dollars per RVU may be different, right? So that's when it comes to, can the physician or that group or whoever's being employed, can they negotiate that? And so a lot of times too is hospitals will renegotiate RVU numbers every year. And a lot of times they're trying to kick that down. So what does the physician have to do? They have to see more patients. They have to see more volume in order to make the same amount of money they did last year. So all that stuff's always going on. And it's important to know that stuff. So if you do change hospitals or locations, you kind of have an idea like, hey, this is great. You know, a lot of hospitals will kind of cap the amount of money you make too, right? So, and the reasoning behind that is like, hey, you know, if there's this incentive to keep doing procedures, right? Sometimes it may not be even the best interest of patients, right? So it's not like you want a physician to just keep doing injections, just make a ton of money, right? So a lot of hospitals may cap you at a certain amount of money, or at some point the dollars per RVU go down, right? So a lot of physicians, I could see on the other side, will be like, well, what's my incentive to kind of work harder if you're going to cap my salary, or after this amount, the dollars per RVU are going to go down, right? So I see it from both ways, right? So that's what a lot of hospital systems use to kind of reimburse physicians right there.
And then just going back to the RVUs, are they like, let's say if it was a procedure where you get 8 RVUs.
Yeah.
That's independent of whether the person or the patient is paying with insurance or
correct,
out of pocket.
Right.
That doesn't matter. It's the same RVU for the physician.
Right. So I feel like that's a way for the physicians who are employed by the hospital to not compete against each other, right? Because then you can imagine, oh, this physician will only see commercial insurance versus, you know, the indigent population of people who can't afford to pay, right? Because that would be messed up, right? Where doctors are supposed to help people regardless if they need our help. So I think that's a way to they kind of use that.
Before we get too far into some of these other topics, can we talk on exactly what you guys do, pain management services as a firm, and how you're set up? Like, are you third parties working in hospitals? Just if you can give us an overview, that'd be great.
Yeah. So my specific clinic is all outpatient. So outpatient means it's a hospital. We're in an office-based location. So essentially that means a doctor's office, right? So a patient's going to come see me, go to my office. I'll see them in clinic, diagnose, evaluate, treat, look at their imaging. And then basically, if indicated, I may offer a procedure to help them with their pain. So that's our setting right there. The main thing I do as an interventional pain management physician Interventional means we're doing procedures, and then obviously we're taking care of patients' pain. So we're doing things like epidural steroid injections for pinched nerve pain that may be going down the leg or the arm. You may be doing things like radio frequency ablation. In layman's terms, that means we're burning the nerve endings that can go to joints, so they don't have back pain from their joints. Or we do that for their knees, for example. So those are the types of things we do. We do pretty simple injections in order to get the best benefit without having them get surgery. And I think that's a philosophy that most physicians have is, hey, let's do the most conservative things first that are least invasive to get the best benefit, right? Because we can always escalate care. So for example, before seeing pain management, patient might get chiropractic care, physical therapy. And if they're good and they're great, then they don't need me, right? If that stuff fails, that's when they see me. And I may do a simple injection or two to see if I can help them. And if it helps them, that's great. But if it doesn't, that's when I say, hey, you might need to see a spine surgeon for an evaluation and get surgery. So it's escalation of care. We always want to do the easiest stuff first.
Got it. And you're clearly very driven, but my understanding is you, for the most part, always want to be practicing and also growing the business, not just like strictly focused on growing the business or anything like that. Can you provide some insight into that? Why you always want to be a practicing physician as well as an entrepreneur, business person?
Yeah, I think in terms of being an entrepreneur at the same time delivering good care and treating patients, I think what I like about that is that there's all these opportunities where we can leverage our skills in order to give better care, treatment options to patients, especially in this time when there's decreasing reimbursements for physicians. So there's a lot of stuff you can do as a physician in order to get some extra income. There's a lot of these things I don't do, right? So for example, some physicians may have a lab in their office where they collect urine specimens, things like that, and they'll get to charge a fee for that. So we don't have that set up, okay? So other physicians may have, hey, I can prescribe back braces or something, right? So that's pretty lucrative. That's called durable medical equipment or DME. So there's a whole setup for that. And essentially you can buy back braces when you prescribe them. I mean, there's some good reimbursement. So I don't do that either, but there's other aspects that I've been drawn to though, such as, and this is like a niche of pain management, personal injury. Okay. And the reason that was so attractive to me is you actually kind of get to practice how you want to practice and treat patients. And what do I mean by that? So a lot of times when we treat patients that are under insurance or Medicare, they have all these guidelines you have to do. For example, someone has back pain. You think it'd be easy for a physician to order an MRI. It's not. They're going to deny it. They're not going to pay for it. So that patient cannot get the MRI. So what's the red tape around that? So for example, Medicare will say, hey, you need to try and fail 6 weeks of conservative therapy, like chiropractic care, physical therapy. You need to try and fail some anti-inflammatories. You need to get an x-ray first. And then if that's negative and you still have back pain after 6 weeks after trying all these, then the MRI is approved. So you can imagine if you have severe back pain as a patient and the physician thinks an MRI will be helpful and they want to order that, and they can't because they got to follow all these rules. And a lot of commercial insurances will follow those Medicare as well. So the cool thing about personal injury and doing lean-based work, so it's actually lean-based, right? Okay. Is I can do whatever I think is appropriate. So for example, if a patient is in a car accident and they had some new severe back pain, they might have some pinched nerve pain going on their leg, numbness, tingling, things like that. And I think an MRI is appropriate. I can order that and they'll get it. It's really nice. I don't have to mess around with this 6 weeks conservative therapy. We get to order what we want and give treatment right away.
Got it. That's really interesting. Yeah. So how do you, as a practice, think through like additional revenue generating opportunities? And I know you personally are more focused on quality care.
Correct.
But you mentioned a few examples of other practices.
Yeah.
Are there like things that you've thought of that you're maybe working on that would help you bring in more revenue and then ultimately help more patients by maybe growing the practice?
Yeah, I think, and this is where it kind of gets a little tricky. And I think we talked about this when we talked on the floor. All these opportunities, when these things come up, sound great initially, right? And you'll have the reps from the urine labs be like, oh, we can set up this lab. It's going to be great. You guys are going to make X amount of money for all these things. But some physicians will get in trouble, right? Because they're going to be hyper focused on all these ancillary income methods, and it may not be in the best interest for the patient, right? So yeah, we all want to, maximize efficiency and generate income, but I think there's a way to do it. I think if you deliver good quality care and get good outcomes, that I think the patients will come. The thing I like about going back to personal injury is that with that, I'm able to treat patients and essentially get reimbursed for what I feel is fair versus what Medicare and other insurances will dictate. Because how we get reimbursed for procedures, it's all dictated by Medicare and insurances. And the problem is every year, these things are getting cut. And so I like to call it like the golden days, like the 90s were just unreal. I mean, all those physicians, they didn't have to see as much volume as we do today to stay open. And they had a nice lifestyle, got to spend time with their patients, didn't focus too much on writing notes, for example. They got to be a doctor and really enjoy that. So it's definitely a little different in terms of climate right now. And I still think a lot of doctors are trying to figure that out without compromising how they practice medicine.
Got it.
Yeah.
You mentioned reps. So one question I have for you, it's a kind of a personal question, but I'm sure a lot of people have the same thought. Mm-hmm. You'll walk into a doctor's office or whatever the case is, and there's free samples of like, it could be sunscreen, it could be whatever.
Sure.
So these are companies that are coming in and using the doctor to advertise. Uh-huh. So is there a lot of pressure on physicians to maybe accept contracts or whatever the case is with certain companies if they have aggressive reps or if they offer incentives to the physicians?
Yeah, so I would say the rep culture has changed a lot, even compared to like 10 years ago. Or 10, 15 years ago. I mean, going back to the 90s, man, those reps would buy like doctors' vacations and stuff. And, hey, come on this free vacation to the Caribbean. Like, it's not like that anymore, man. So most of what we see now is maybe they may come and bring lunch to the office and kind of discuss their device that they're trying to introduce us to, or this medication. I personally don't do much of that. And the reason why is a lot of these device companies, they're so new, right? And even though they might have studies, you got to look at the studies. Is it paid by them, or, is it skewed a little bit? So you got to really make sure, because you don't want to implant a device in a patient without kind of vetting it, mm-hmm. because you want to make sure that patient does well, right? So there's definitely a ton of devices that have been out in the past where everybody drank Kool-Aid. Now all these patients have this device in them and it's not working too well, right? So there's a lot of that. And so you just kind of have to take it with a grain of salt. I'm sure. So going back to your question, I would say there is a bunch of physicians, and this is not a bad thing, right? So they're called KOLs, or key opinion leaders. Okay. And essentially what they do is that they're kind of speakers for that company, right? So obviously, if you talk to a KOL for this device company, he's gonna be like, oh, this is great. It's helping everybody. Look at these studies, right? And there's a ton of that, right? So you just got to understand and know him, like, okay, even though I like him, he's a great doctor, you got to take it with a grain of salt, because this other KOL for this other company is like, oh, they're just not great. And so it's like, who do you believe, right? So personally, I wait when these new devices come out and just see from normal physicians, like, hey, what are your outcomes with this? Is this good? You know, is the patient better? Things like that. But there's definitely, I would say, speakers or key opinion leaders that definitely are heavily sometimes influenced by these companies for sure, because they're getting paid by them.
Got it. So it's not as big of an issue today as it was, but it's still possibly something to be cautious of if
100%,
you're a
right.
patient.
Yeah, 100%. Right.
Okay. And so we talked about your firm not necessarily looking at other opportunities to increase revenue aside from the core business. So
Right.
keeping the core business.
Mm-hmm.
How are you driving efficiency? Because you mentioned seeing more patients, still providing quality care.
Right.
What's maybe like low hanging fruit that other people can implement in their practices or in even in their businesses to try to drive that efficiency that you guys have?
Yeah. So I would say in terms of efficiency, you're really only as quick or efficient as your slowest person, because there's so many working pieces in a clinic. It's not just me. I wish it was just me, because then I'd be crushing it, but like there's a lot of pieces, right? So there's the front desk staff, there's schedulers, right? So if the schedulers aren't filling your schedule or clinic appointments, then there's all these gaps. So that's not efficient, right? So there's spaces where potential patients could be filled in, right? So that happens, right? Then you have your medical assistants who get the intake from the patient, enter their notes, and that takes time too. So if they're slow on that, then you're kind of extending your day times like 20 patients, right? So there's that, and then there's that procedure aspect. So you'll have like an X-ray tech who moves the X-ray machine so you could do your procedures, and then you have the nurse, and they may monitor vital signs and give sedation. So if they're not quick at getting that patient back, and they're taking a while to turn over the room, that's a difference between, for example, let's just say 8 procedures in the morning versus 18, right? And then if you look at the reimbursement for that, that's huge. And if you times that by 5 days in a week, and then over the month, like, it's a big deal, right? And I'm not saying, hey, let's do procedures as quick as we can unsafely. No, a lot of these procedures are super simple. So for example, like an epidural steroid injection will take like 2 minutes, right? So if you look at that, and we're still trying to perfect the way our clinic moves as well. But if you look at that, and you say, hey, why is it taking 20 minutes for a 2-minute procedure? Those are things you have to figure out. And like, is it the staff? Do we need to get new people? I would say a lot of the times too, is you got to get the right people to be working for you, right? So you want someone in your clinic who is proactive, who wants to solve problems, who is always trying to help out, who's trying to be a team player. And there's definitely, just like in any industry, you hire the wrong person, it's really going to drag you down.
Team development sounds like it's extremely important. What are some things that you're currently implementing or some challenges, mistakes that you've overcome when it comes to building the right team and having those great people on your team so you guys can continue to provide great care?
Yeah, I think a lot of it comes down, again, to the people you hire. It's hard, for example, if you go into a clinic with an established work culture that is inefficient or not right. My first job out of fellowship, it was beautiful, and kind of jealous that I don't have a setup like this, but those guys knew how to run a clinic and do procedures very efficiently while giving good quality care. You can go to a different clinic, and there's this culture of kind of like taking your time or not really working too hard. And it's hard, especially if that culture has been there for like 20 years. Like, how are you going to change that, right? You have to change everybody's perspective and point of view. And you also have to kind of explain or try to convince them why we can be better, right? So I think it's hard. So that's why I go back to, hey, you got to hire the right people. And sometimes I think it's easier if, instead of trying to convince these people to work harder, just get maybe just get new people.
So when it comes to hiring, for example, and I'd like to talk about some of the other things when it comes to building the right team, but hiring in particular, without the business background, are you relying a lot on third parties like recruiters, or do you handle it in-house?
Yeah. So essentially, when we're hiring staff like medical assistants, X-ray techs, nurses, no, we personally will post a job on like Indeed, right? We'll get some CVs, we'll look at them, see if they're qualified. We'll schedule interviews, and I'll interview myself. A lot of times when you talk to them, you can kind of have an idea of their mindset or what they're trying to accomplish with this job, right? So we always look for, again, go-getters, people who want to work in a fast-paced environment, that have good attitudes, that can work with different personalities. And there's definitely been times that we've hired the wrong people, and you kind of just have to get rid of them right away, because if you keep that around, it's going to destroy your clinic.
And then in a medical setting, are you still doing things like one-to-ones or team meetings at a regular cadence? And then do you have core values that you try to train people on?
Love that question. So I don't believe we have core values. I mean, I should look, but I'm pretty sure we don't. Okay. And I think that's important. I've read a lot about that. And I think I would like to implement that into my clinic, right? Core values for sure. And we have to live by those. The meetings though, right? So again, I would love to have meetings and one-on-ones. I think coming out of medical school and residency, that's not taught to us. So we don't know we should be doing that. And we definitely should. The funny thing is, if you go to a place where they don't do it, it's really hard to get staff on board with that, right? And of course, as the boss, you could say, hey, we're going to do this meeting, whatever. But there's other doctors, right, who are still used to that old way, that old culture, and they may not be into it either. So it's really hard to kind of push new ideas when everybody's not on the same page, right? But I think I would love to implement those, and I think we're trying to. I think if we get the right people too, we can head that direction.
That's really interesting that it's not commonplace in the medical world. So I have to ask another question then.
Yeah.
When I go to, like, let's just say a Mercy,
Mm-hmm.
if it's one department or another, now that I think about it, because you mentioned that, I don't feel like there's true consistency when it comes to just the way folks are maybe presenting themselves, or, you know, it's not the same as if I were to go to, like, and it's not the example is not perfect, but it's not the same if I were to go to, like, a retail store. You know,
Right.
it's there, the consistency is not there in the
Right.
customer interaction.
Correct.
So do you think that it's difficult to provide that type of consistency in your world because, as you alluded to, you're being trained to kind of operate in a silo? And then is there also maybe some sort of ego if, like, a physician were to work for your practice, they want to be themselves versus be this large organization? Does that make sense at all?
Yeah. Yeah. I think it totally makes sense. And for sure that's present, I would say, in all medical fields, right? So no physician, even though you're the same type of doctor, is going to practice the same. And I guess that's the thing, right? Is a physician, we always want to do what we think is the best, but a lot of the times it's very different. Okay. Even in pain management as well. So when you get those guys that work together too, there may be some headbutting in terms of how they want to schedule patients or treat patients or run the clinic. So, and combine that with different personalities, it's a whole thing, right? I think, especially if you go in between specialties, right, communicating with other specialties, that's a whole other aspect that you kind of have to take into consideration as well, because they are not going to think of treatment how your specialty does. And so they're kind of focused on this thing, and you're kind of focused on this thing, and sometimes it doesn't line up a lot too. So it's interesting. That's where we're at right now, you know.
Got it. That makes sense.
Yeah.
I want to, we have maybe 10 or 15 minutes left, and I want to be respectful of your time. I have a couple of questions that may be a little controversial depending on how you answer them.
Sure.
So if you don't want to answer them, Feel free. What are your thoughts on the state of the US healthcare system today? And if you could change one thing about it, what would it be?
State of the US healthcare system right now, I think there's definitely room for improvement. What's hard and what I see personally as a doctor is going back to what I've said before. A lot of patients are used to getting some type of care and some coverage for their care, and now it's being denied, right? So, for example, we used to do SI joint. So there's a big joint in your lower back called the sacroiliac joint. We used to offer something called the radio frequency ablation there, right? And I'm not saying it works for everybody, but in those patients, it worked really well. They could avoid a fusion at that joint, right? So something super invasive. And the SI joint radio frequency ablation was taken away from us maybe like 2 years ago. And so nobody gets that covered by Medicare. Nobody gets that covered by insurance. Insurance deems that experimental. So that's usually what happens when procedures are taken away. Like, oh, it's experimental. So there's no great evidence for it. So what does that mean? Even though this patient had, let's say, 80% improvement in pain for a year, they can't get that repeated now. So what happens is the patient's going to have to cover that cost themselves now, right? Because we can't just do it for free, right? We need to pay for the nurse. We need to pay for the equipment. We need to pay for the C-arm tech things, right? The materials. And unfortunately, there's a lot of procedures that are taken away from insurance companies. And a lot of these patients are kind of getting left behind, right? So that, and then, man, insurance companies, they deny a lot of care, right? So it's kind of bothersome when, for example, a patient's been on a med, stable on this med, it's been helping with their pain or whatever disease they have. And then all of a sudden they're like, oh, it's not covered anymore. So what are we supposed to do, right? We talk to the insurance company. There's a lot of physicians that work for the insurance companies, and we do something called peer-to-peers, where we call the doctor and like, hey, you know what? They tried and failed X, Y, and Z. They've been stable on it. Can you cover this? And, sometimes they'll be like, okay, we will approve that. But I think a lot of times these things are getting denied because they're saving a lot of money, right? They don't want to cover that stuff. So I think that we need to figure something out for that, right? Because I feel like we're going the wrong direction there.
The peer-to-peer, would the quality of your doctor help you? Like, for example, if I have a doctor or physician who is better at what they do, could they convince the insurance company to provide me with some sort of care that maybe another doctor couldn't if they couldn't make a strong argument?
Well, yeah. So that's the thing, right? So when you do it peer to peer, you're essentially kind of explaining medical necessity and why you think this service or medication should be covered or provided. Yeah. So if you have a physician who doesn't know what they're talking about, yeah, it's not going to get covered. But if you're, concise, if you are objective, have imaging studies, what they've tried and failed in the past, why it's helped in the past before, then I think most doctors will be reasonable and approve things. But sometimes, and there's a lot of doctors that do this, they literally, you say your whole argument and they just read the insurance policy word for word and be like, it's not covered. And you're like, okay, well, what was the point of that? So there's a lot of that still.
Sure.
And it's funny because sometimes the doctors that you're doing this peer-to-peer with, they're not even specialists in your field, right? So for example, like you might have a cardiologist or something who does this as a side gig to make some extra income. So this is a way to make extra income too. You could do peer-to-peers or work for an insurance company. But they may be denying a pain management procedure, even though they don't know anything about pain, right? So that's kind of messed up, right? So there's a lot of that too. And I get it, the policy is the policy. I'll always try to advocate for my patient.
So if I'm hearing you, you would prefer there was more consistency, clarity, and then also maybe some sort of fallback for folks who can't get things covered by insurance, like, or maybe like a bigger safety net for those types of procedures. Is that fair to say?
I mean, I don't know what the right answer is for that, but I think there should be a way that patients can get coverage or afford care when they previously were able to. And I don't know what the right answer is for that. It's hard.
I agree. I agree. We talked early on about like the different specialties, subspecialties. Do you see in your world maybe large hospital systems or private equity firms specializing or buying like one specialty or subspecialty and then rinse and repeating and acquiring?
100%. So it's happening right now in a bunch of different specialties. I've seen it personally in the pain space. So pain management, right? Private equity is buying all these pain clinics, right? And essentially what they're doing is they're buying this like, hey, we could run this more efficiently by doing this. We could generate income by doing these things. And the business side, we get it, right? I understand that concept, right? The problem is a lot of times when private equity acquires these clinics, what happens is that these docs have to change the way they practice in order to fit that picture. And a lot of times the quality of care goes down, right? So, I mean, I think this was an example many years ago in St. Louis. Some private equity company bought some clinics, and then the docs essentially sold their clinics to this private equity and became employees. Well, the private equity is like, hey, you need to order urine drug screens every 2 weeks or something, right? Because we talked about that as a income generator, and they weren't comfortable with that because what's the reason behind that, right? Besides making money. So there's like things like that, or hey, do this procedure on this patient. And it's not just happening in pain. I feel like it's happening in like ER, anesthesia, radiology. It's happening everywhere. So I think it can be done where you can still deliver good care, but I think a lot of it, from what I've seen, really kind of will make care be worse, honestly, in order to maximize profits. So I think, and that's the tough part about being a doctor, right? We want to be fairly compensated for what we all do and what we provide and our training and all our sacrifice. But our main goal is doctors. So I think there's a balance, and I think there's a way to do it. It's just very hard to do that.
Got it. Is there a way for a patient to be able to tell if their provider is owned by private equity or not?
Some clinics will operate under the same name.
Okay.
So sometimes it may not be easy. And then some very obvious, like, oh, we're part of this pain and spine group nationally. And then you go to the website and there's like dots everywhere across the nation and stuff like that. So sometimes, yes, it may be obvious like that. And sometimes no.
And it doesn't sound like you're on that path, but it could be a path for a very enterprising physician to grow to a few locations and then package them up and sell them.
100%. And a lot of physicians are doing that, and I don't think that's necessarily a bad thing too, especially if they're able to kind of have some sort of control of those clinics. So they're still being true to how they want to practice. And there's definitely private equity groups that allow that. So, there's bad private equity and there's good right there. And I've seen some good examples of that, actually.
Got it. If you were a patient, what would you look for in your healthcare provider?
So as a patient, especially when looking for a good physician, what I like to see is that they talk to you and spend time with you and try to figure out what's really going on, right? They're not too rushed. And, we always have time constraints when we have patients in clinic. I can't spend like an hour with the patient, but I can spend, 20 minutes, really take a good history. Besides that, you have a good physician when they actually examine you. What do I mean by that? I mean, they lay hands on you, they do a physical exam on you. Because a lot of doctors, and I call it lazy medicine, is when they look at the x-ray of the eye and come up with a diagnosis and treatment plan before even talking to the patient, right? So like that's literally looking at an MRI before you walk in and be like, oh, your problem's at L4, L5 disc without even talking to the patient, right? So I think that is bad medicine. I think that's lazy medicine because a lot of the times we have these imaging results, but they don't correlate with the patient's pain. So what do I mean by that? You can get 10 MRIs on people without back pain, and they could have spinal canal stenosis, they could have pinched nerves, they could have arthritis in those joints. But because they don't have symptoms, it doesn't mean you're going to chase after it, treat it, right? So same thing with people with pain. Doesn't mean that whatever shows up on the imaging is the source of the pain. So that's why for a good physician, you want them to examine you, right? And that's like basic med school stuff that we're taught, but a lot of people will lose that as they're in practice, right? Because maybe they're faster, they can see more patients, but what ends up happening with those physicians is that they end up treating the wrong things. Those patients may get procedures that are not going to help them or surgeries that are not going to help them, and they're worse off, right? And I see that all the time too. Patients come in for second opinion. They're like, hey, I got this done. I'm like, why? Your symptoms don't match that. I mean, I understand it's on the imaging, but your symptoms don't match that. Wouldn't have done that. Would do this. We do the right procedure because I took the time to listen to them, and they get better, right? So besides that, you want someone who has good bedside manner that you're comfortable with. And I think with all those things, you can have a great relationship.
Got it. And I like the way you describe it as a relationship. And, I think that's very important for it to be a back and forth and not just one directional communication.
Correct. Yeah. I mean, essentially, the patients, they're grown adults, right? They're grown men and women. I can't tell them what to do, right? As a physician, my job is to be real with them, tell them the appropriate things to do, give them the options that we have, and it's their decision. It's their body. So they can do whatever they want, right? So I tell patients to quit smoking all the time. They may not listen, and that's fine, but they just have to be prepared to deal with those consequences from their actions. Right. And as long as we're on the same page, it's fine.
Sure. That makes sense. And actions do have consequences.
100%.
So I end each show with what's called the hole-in-one, your greatest piece of advice that you can provide that someone can implement in either their life or business. Do you have any advice you can share?
Yeah. Well, this hole-in-one, it's funny. I was thinking about this, and I it sounds kind of cliche, but take care of your health. I mean, seriously. You only have one body, right? And I think a lot of us, me too, I've taken my health for granted, right? So in our 20s and our 30s, you feel like you can do anything, eat whatever, not exercise. But it's funny, I turned 40 like 2 months ago, and I feel like, oh man, I got some knee pain now, I got some back pain. It's like, man, maybe I should have rested more, eaten the right things or things like that. But I would really focus on taking care of your health. And the reason why is you may not feel that all these bad choices have an effect on you immediately, but all these small things that you do over time will end up having big changes, big consequences in your body later. And then when you get to you're going to wish you could rewind 5 years ago and do things differently, right? So for example, if you're eating like McDonald's every day, right? You don't necessarily feel bad, right? But slowly you're getting all these plaques in your arteries, right? That are going to close up. And then all of a sudden you have this chest pain, you have a heart attack, and then you could die, right? So there's a lot of those things. In terms of business, I would just say personally, when I think about this, is I would always say, go all out, do the best that you can do. And I think even if you're not getting the benefits with that, people will recognize that. The people you work with will recognize that. It will motivate them. It will inspire them. And I feel like if you put your best foot forward and always try your hardest and do the best that you can, I think the success will always follow you as well.
That's awesome. I do have a follow-up.
Sure.
40 is not old at all. 40 is very young, but I would say you look great for 40.
Thanks.
So what are you doing for your health?
Oh man, I have like a whole routine now, man. It's crazy. So one, and I think this is the most important thing. I mean, you have to get sleep. Sleep is so important. So personally, I get 8 hours of sleep a night. Me and my wife go to bed at 9:00, wake up at 5:30. I have coffee, and I personally do intermittent fasting, right? So I'll probably eat between like 12 and 6. There's studies have shown that when you have this period of time where you're not eating, what happens is your body experiences something called autophagy. So the bad cells kind of like break down and these other cells eat them. So it kind of like recycles components, right? So it kind of keeps these healthy cells there and the bad cells kind of get recycled, right? So that's good. So I do that. And this is kind of like, I would say, alternative medicine stuff too, right? Because I do cold plunges every day. And cold plunges have been shown to kind of reduce inflammatory markers and cytokines in your blood. So I do that, but also builds grit, because going into 50 degrees doesn't sound cold, but it is cold. If you try it, it is not fun. So me and my wife do that every morning for like 3 to 5 minutes. And after that, I'll do some red light therapy in my basement. And then we just try to eat a ton of fiber, right? So fiber, this might be your whole one too. Like seriously, people who want some easy advice that's practical for health, our diets are so full of like simple carbs and simple sugars, right? So when you eat that, blood glucose spikes, you're more at risk for diabetes, all these inflammatory diseases, right? And I'm not saying you should eat those all the time. Like obviously you want to focus on like complex carbohydrates, vegetables, grains, things like that, lean proteins. But if you're in a pinch and you have to eat something bad, you can kind of mitigate that blood sugar spike by just drinking fiber 30 minutes before that meal. Because the fiber kind of binds to the sugars and releases it slowly, so you don't get that glucose spike. And the cool thing about that is I had experimented with one of those glucose monitors on your arm, and I would eat like a meal, like White Castles, like super bad, like went to like 200. I'm like, oh my God, like 3 White Castles did that, right?
Wow.
And then you do that with fiber and it blunts that increase. So I think that's honestly one of the biggest hacks you can do in terms of mitigating risk with eating unhealthy. So fiber, sleep, fasting, all good stuff. Sunscreen, do sunscreen.
And then if you're feeling like you're getting good results, add in the cold plunge and the red light therapy.
Yeah, I mean, so all those things, yeah. I mean, so the basics is sleep, eat the appropriate foods, fiber. Obviously, don't do like cold plunges and red light and all this other stuff before getting the basics done, right? You got to get the basics done. That's just like icing on the cake right there.
Got it. Well, thanks for your time, Calvin. Really
Thank you.
appreciate it.
Thanks for having me.